Okay, well, while people are coming in, I will get started now. Um, we are here for our June Cup of Tea event. I'll be your host. I'm Ivana Rostevsky. I'm the parent in research with the Damaris Lab. And today I will be going over just a few announcements in the beginning. I will share with you my parent and research updates. And then I will go into the information about what a cup of tea is, and then the article summary and our discussion with the group at the end. So we will definitely have time for questions and discussing all the different aspects of the article that we hear today. We are a meeting that is before another meeting happening at 9 o'clock Eastern time for our health professionals. So I'm going to try to wrap everything up by 9 o'clock to make sure all the key details that we discuss can be heard by all attendees, but you're welcome to stay afterwards to continue discussion and sort of a community engagement if you're interested. As we begin our event, I would like to ask everyone to just keep your mic muted for now until we get to our Q&A at the end. But keep your camera on if that's okay. This kind of makes us feel like we're part of the community here. And I would also ask if anyone has their name listed in maybe a corporate name or something, if you have just at least your first name, or if you would like to share, just so we can kind of engage and at least pretend like maybe we're in the same room and having a conversation together as a group. During the presentation and the event tonight, if you have any questions or there's any issues that you're encountering, if you can send an email to retinoblastoma.research@sickkids.ca, or if you can find Roxanne in the chat and you can send her a message, hopefully we'll be able to help out. But we haven't had any issues in the past, so I'll keep my fingers crossed for our good luck. So the announcements, what I wanted to share with you is our retinoblastoma research community. I know a lot of you have heard of this already. There might be some in the audience who haven't, or maybe somebody who's watching this on YouTube for the first time or on our podcast. But the retinoblastoma research community was created to connect people who are personally or professionally connected to retinoblastoma and are interested in research. This is an international sign up, and it's welcome for all retinoblastoma patients. And we use the term patient often, which includes family and friends, for researchers and health professionals. So the best way to keep in touch with these kind of events and other types of opportunities is by signing up, and then you'll be receiving newsletters, emails, calendar invitations. So the link will be, yep, it is up in the chat now. So you could click on there and sign up, please. And if you are not sure if you've signed up already, you could send email to that email address that is already listed in the chat, and I could check for you, and you don't have to sign up twice, but this is the best way to stay in touch and learn about all these events and opportunities. One of the studies I wanted to share with you guys that's ongoing right now is addressing our priority 3 out of our top 10 retinoblastoma research priorities. We had, in 2017, had established the top 10 retinoblastoma research priorities, and number 3 seeks to address the psychosocial needs of retinoblastoma survivors and families. And the study was launched last August. So you can help us out in addressing this priority by filling out the questionnaire if you are a retinoblastoma parent or survivor and are over the age of 16 and had at least part of the treatment in Canada. The link will be in the chat. Yep, there it is. And if you already have participated, or maybe you don't fit the criteria but know somebody who does, please share the study. Currently, well, as of our time of our newsletter that was launched just a few weeks ago, we had 51 participants completed the survey, and we have a target of 400. So we definitely need a lot more participants to fill out the study, so we have a really great pool of information to be able to address the priority with everyone's experience addressed. I mentioned there was a June newsletter that launched, so this is just similar information that you would have received if you are in the retinoblastoma research community. So the 2023 Retinoblastoma Research Symposium was a really great event that we had in January. Now the video recordings are up on our YouTube channel. If you search Retinoblastoma Research, that's the channel name, and you'll be able to find all the video recordings there. Our next quarterly meeting for the Canadian Retinoblastoma Research Advisory Board will be happening on July 26th at 8 p.m. Eastern Time. You can, if you don't have this already in your calendar or have any questions about the meeting or any other questions about it, you can send the email to that email address and I will get back to you as soon as possible. And I am looking for more volunteers for our Cup of Tea events. So if you are new here, you can see kind of how the event goes tonight. But if this is something that you might be interested in to do in the future, please let me know. I would love to share information with you about what is required and time commitments that are needed, and the benefits of participating. So let me know if this is something you're interested in. Okay, so some background information. The Cup of Tea is an event that's intended to bring the Canadian retinoblastoma community together for an informal discussion about a research article. And discussions center around articles which members of our Canadian Retinoblastoma Research Advisory Board, or CRAB, members have created these summaries for. The past Cup of Tea recordings are available on our YouTube channel, and you'll see this full presentation, or you can listen to this presentation in Spotify. Our channels are both called Retinoblastoma Research, and all the past events are there for you to find. So how we develop the Cup of Tea, this is a very simple outline. There's a lot more steps involved and more detail, but basically what happens is a patient and a non-patient partner come together to review an article. They read it through, they work together on creating a plain language summary, which is written by the patient partner, but our non-patient partner really helps us. I'm going to say us because I help in the guidance of the process. So I also learn, and they help us understand the research behind it so that we can then, through discussions, create a plain language summary that's accurate. And then that is what's presented at this Cup of Tea presentation. So today's Cup of Tea will discuss the article Considerations for the Use of Circular Tumor DNA Sequencing as a Screening Tool in Cancer Predisposition Syndromes. The plain language summary is available on our website, www.rbcanadaresearch.com, and all our past Cup of Tea summaries are there as well. Okay, so our guest speakers today, we have Mary Connolly Wilson is our patient partner who'll be presenting the plain language summary. Mary comes from a large family affected by retinoblastoma and is interested in second cancer screening that might lead to early detection. You probably recognize Mary. She's a very active member in our retinoblastoma research community and has experience in hosting the Cup of Tea. We have Stephanie Kletke, who's a pediatric ophthalmologist in the retinoblastoma program at the Hospital for Sick Children and is assistant professor at the University of Toronto. One of Stephanie's research interests is second cancer surveillance in heritable retinoblastoma. And we have a special guest attending as well, We have Julia Sobotka, who's a research genetic counselor at the Princess Margaret Cancer Center and a member of the CHARM team. CHARM stands for cfDNA in hereditary and high-risk malignancies. CHARM aims to improve early cancer detection by developing a blood test to predict cancer development in carriers using circulating DNA. And I will pass it over to Mary, who will help us all understand that a little bit better.
So hopefully I will be able to help you understand it a little bit better. So as we said, the article tonight that we chose was considerations for the use of circulating tumor DNA sequencing as a screening tool in cancer predisposition syndromes. So just to give you a little bit more background about why I have such an interest in this, I come from a large family affected with retinoblastoma, and there are 17 people in my family with an actual mutation in the RB gene. I have 2 brothers, an uncle, and 8 cousins who all had RB. And I was found to have a retinoma at age 22 when I was involved in RB research at that time. And when DNA testing on our family in 1994 revealed the mutation in the RB gene, the at-risk members were then tested, and DNA testing confirmed that my mom, an uncle, and an aunt, all who had children with RB, were mutation positive as expected, even though they didn't have any clinical manifestations. And testing also revealed that another uncle, as well as one of my nieces, who again had no clinical manifestation of RB, also had the same deletion of exons 24 and 25 of the RB gene. So therefore, there are 17 individuals in the family who are at risk for second cancers, and some of them have gone on to have second cancers, such as melanoma, brain cancer, bladder, and colon cancer. So I'm very interested in any type of screening for second cancers that might lead to early detection for people with the RB1 gene. So research has shown that individuals with mutations in the RB1 gene are at an increased risk for second cancers. And the most common probably is osteosarcoma, which is a bone cancer, melanoma, which is cancer of the skin, soft tissue sarcomas, which affect the colon, stomach, and bladder, leiomyosarcomas, which are in the smooth muscle of the uterus, and also brain and lung cancers. And to date, there's no Canadian protocol to screen for second cancers for RB survivors. So looking for ways to help detect these cancers early is very important. So next slide. So to understand the concepts in this paper, I feel it's really important to go through some basic explanations and definitions of some of the sort of technical information within it. So cell-free DNA was the first term, and DNA is naturally found in cells. So small pieces of DNA are released into the blood as a normal part of cell death. And this is basically referred to as cell-free DNA, or you might hear me talking about CF DNA. So same thing. The second is ctDNA, or circulating tumor DNA. So when a cancer is present, tumor cells also release cfDNA into the blood, and this is referred to as circulating tumor DNA, or ctDNA. So the next slide. Liquid biopsy is a lab test done on blood, urine, or other body fluid to look for ctDNA, or circulating tumor DNA. And this testing allows multiple samples to be taken over time to detect genetic changes in a tumor and potentially detect cancer at an early stage. The next one was cancer predisposition syndrome. And this is a type of inherited disorder in which there are higher than normal risk of certain types of cancer. So these hereditary cancer syndromes are caused by changes in certain genes passed from parents to children. And in hereditary cancer syndromes, certain patterns of cancer may be seen within families, with the same type of cancer developing in relatives, cancer occurring at an earlier age, or having two or more types of cancer in the same person. Basically, a genetic mutation that increases the chances of developing cancer at an earlier age compared to the general population. So the purpose of the paper, this paper highlights the potential use of this ctDNA analysis from blood, or what we call a liquid biopsy, to study, diagnose, and track cancer, and for pre-symptomatic cancer detection in individuals at increased risk of hereditary cancers, like those of us with RB. Okay, now this may seem like a very busy slide, and I'm going to try and explain it to you because some people learn visually and some people learn by reading. So we tried to do it both ways. So this diagram was actually presented in the article, and it shows how ctDNA, along with radiological and physical examination, can be used for patient screening in cancer predisposition syndromes. So the first pictorial on the left shows a patient with a genetic predisposition to cancer, like RB, where the change in the gene leads to cancer. So there are several examples of these syndromes. One of them is Li-Fraumeni syndrome, or LFS, which you'll see on the left side pictorial. And in that syndrome, you can have breast cancer, brain cancer, osteosarcomas, and soft tissue sarcomas. And then another common one is Lynch syndrome, where there can be cancers of the colon, stomach, uterus, and kidney. And there are other cancer predisposition syndromes with other cancer risks. In the bottom of the left side pictorial, we see that tumor cells are circulating within the patient's blood. And certain tests can be done looking for specific DNA changes in those circulating tumor cells that may be predictive for a tumor before symptoms actually appear in an individual patient. In the next pictorial, headed by early detection, we see that ctDNA testing can be done on a patient over time. So if you look at the blood drops on the bottom, the first two red blood drops don't show any circulating tumor DNA. And at some point later, as seen by the blood drop with the green halo, ctDNA is found, therefore evidence of a tumor in the system. And this may be seen before a person notices any symptoms or before a tumor is seen on X-ray or any kind of radiological examination. The same testing may be used to actually monitor the treatment of the cancer, as in the middle pictorial, or the pink one. And in the last pictorial on the right, we see how it can be used to monitor for recurring or new cancers. So hopefully that explains kind of what they're trying to do in this article. So next slide. So benefits of screening with ctDNA. So screening through a blood test avoids certain risks associated with other screening methods. So the MRI, which in young children, there's usually, if you use MRI, there's usually a need for anesthesia. There's also sometimes a need for contrast agents to be used for MRI or CT scans. And there's certain risks with using anesthetic or contrast agents. And there's also the risk of radiation itself in people who are already at an increased risk for a second cancer. So the goal to keep is really to keep radiation to a minimum. However, with current screening for many of the cancer predisposition syndromes, most of the screening does include some type of radiological screening. So, there are certain, I guess, risks with the current screening. With the ctDNA screening, it can be repeated over time, as we saw in the pictorial, to monitor for changes in the amount or the type of ctDNA. So that's a plus. And over time, as the technology improves and costs hopefully decrease, ctDNA screening may be less costly than present radiological and other screening methods. So the next slide, we looked at, in the study, there was a number of different, talked about a number of different studies exploring approaches to this blood-based screening for cancer. I'm only going to go through a couple. So there was one called Detect-A study, and it showed that a combination of cfDNA testing and clinical imaging can safely detect cancer in individuals without a previous cancer diagnosis. And then there was another study called the TIZU longitudinal study, and that found that cfDNA testing had the ability to actually predict cancer as early as 4 years before clinical diagnosis. We'll go to the next slide. Then they talked about CHARM, which you'll hear more about later, which is circulating tumor DNA in hereditary and high-risk malignancies. And this CHARM study was underway to store cfDNA from individuals with cancer predisposition syndromes here in Canada. And this allows for comparison of cfDNA testing to the standard screening methods for early tumor detection. Okay, next slide. So when we look at considerations for future research, the authors acknowledged there were questions and challenges to be addressed. One was the cost, the feasibility of actually using this testing. They talked about the advantages and limitations of various testing types and techniques. But they did conclude that applying ctDNA testing as a screening and surveillance tool appears to be justified and could be revolutionary for patient care, particularly for genetically at-risk individuals. So for me, that was an extremely important part of that. So now we will, if we can, we will put you on to Julia, who is the program manager for CHARM. And hopefully she will give us a brief summary of how these technologies are currently being studied for early cancer screening in individuals with cancer predisposition across Canada.
Perfect. Thank you, Mary. Can everyone hear me okay? Yeah, perfect. And Ivana, are you going to share the slides or did you want me to share?
Oh, I can continue sharing.
Okay, perfect. Yeah, so it's very nice to be here. I'm very happy to share a little bit about CHARM. I will say I'm fairly new to the CHARM team, so hopefully I can answer questions to your liking, but if there's anything that I'm not able to answer, I can pass it along and then get back to you at another time by email. So I started off with a background slide. I know Mary did a great job already of talking a bit about what is cell-free DNA and circulating tumor DNA, but I know even for me, when I first learned about it, it was complicated and I come from a science background. So I figured going through it again one more time with a slightly different picture can kind of clarify things for people who might have not totally understood it the first time. So what I'm showing on the slide here is a diagram of a blood vessel. So in all our circulation in our blood, we have these tiny pieces of DNA that we call cell-free DNA. And as Mary mentioned, these are when our cells get older, they kind of break open and release this DNA into our blood circulation. So we all have these. This is normal. This is normally coming from healthy tissue, healthy cells. Now, if someone has a cancer or tumor cells can also break open and release their DNA into the bloodstream. So if someone has cancer, most of the DNA pieces floating in the blood are going to be coming from healthy cells, but then a small amount are also going to be coming from cancer cells. And the DNA that's coming from the cancer cells looks a little different than the DNA that's coming from the healthy cells. So the cancer DNA has these markers on it. You can kind of imagine it like little flags kind of sticking onto that DNA that distinguishes it from the healthy DNA. And so we've talked a little bit about the term circulating tumor DNA, cell-free DNA. So circulating tumor DNA is kind of a more specific category of cell-free DNA. So that cell-free DNA is kind of the umbrella that talks about all those bits of DNA floating in the blood. Circulating tumor DNA is specific, those bits of DNA that are coming from cancer. And so what we do and what really is at the core of CHARM is taking blood samples from our patients, participants who have what we call hereditary cancer syndrome. So individuals, like many of you are probably quite already familiar with, who are born with an increased risk of having cancers over their lifetime. And we look at their blood sample, we look specifically at that cell-free DNA that's floating around in their blood, and we look for those markers, for those flags. So can we see anything that's coming like it looks like it might be coming from cancer? And so that's really kind of how cell-free DNA and this blood test works and how it can be used to detect cancer. So you can move to the next slide, Ivana. So a little bit more about CHARM specifically. So mentioned it a few times already. It's a long title. So CHARM stands for Circulating Tumor DNA in Hereditary and High-Risk Malignancies. It's a study that's led by Doctors Trevor Pugh and Raymond Kin out of Princess Margaret. And like I mentioned on the previous slide, and like the name implies, we're looking and working with patients who are themselves at a high risk of developing cancer. And we're looking in their blood to see if we can find any cell-free DNA that's coming from tumors. And our goal, and the goal of CHARM, is really to develop a blood test for early cancer detection. So what I'm showing on the slide here is a map of Canada. And really what I wanted to highlight at the top is that we have CHARM sites all across the country. So in British Columbia, in Ontario, of course, in Quebec, in Newfoundland and Labrador, and in Nova Scotia. And across all these sites, we have patients who are enrolled with various hereditary cancer syndromes who are donating their blood to the study to help us really develop this test for early cancer detection. The only other thing I wanted to highlight on the slide is the little Life Labs and DynaCare logo. So many of our patients don't live close to where the hospital is and where we're located. So for example, in Ontario, we have patients at Sick Kids, or our CHARM sites are at Sick Kids, UHN, Mount Sinai, they're all downtown Toronto. But of course, many of our patients are spread out all across the province. So what we had done early on is partnered with Life Labs and DynaCare so that when patients are donating their blood to our research study, they can do it at a local community lab, and then that blood can be shipped to us. They don't have to come all the way into the city to do that. So of course, I hope it's quite a bit less burdensome for patients. They don't have to worry about taking time off of work, cost of transportation. If you're downtown, figuring out parking, it's a lot to consider. So we try to make things as easy as possible for our patients because we do really appreciate their contributions, of course. And then a little bit about CHARM to date. And then my last slide is just about the changes that are happening to CHARM moving forward. So to date, CHARM, the study has been very much what we call, the word we use is retrospective, which really just means that we collect the blood, we look at the cell-free DNA, but the purpose has been really for test development. We haven't been returning any results to our patients just yet. So in terms of test development, we're really looking at that cell-free DNA and seeing, can we find anything coming from tumors? Or does it all look like it's healthy cell-free DNA? So what I'm showing on the slide here is just kind of the general steps for our current CHARM study. So first, from our participants, we collect blood every 6 months to a year, depending on what's comfortable and convenient for participants. So across Canada, we have just under 2,000 patients enrolled. Most of the patients have either hereditary breast and ovarian cancer, Lynch syndrome, neurofibromatosis type 1, or Li-Fraumeni syndrome. And I know Mary touched on a few of these, and the paper touched on these as well. We are certainly expanding to other cancer syndromes as well. We just kind of had to focus our efforts initially into certain groups. But we actually did recruit an RB1 carrier at UHN. And I know Dr. Fleck can talk a little bit about the potential plan at Sick Kids for recruiting additional RB1 carriers. So we collect these patient samples, and to date we've collected a little over 3,500 samples from our participants. And as I said, the goal has been test development. So when we collect enough samples for a particular group of patients, so for a particular syndrome, we then go ahead and sequence and read through all that DNA in the blood. And then we have a lovely team of bioinformaticians and computational biologists who are really able to read through and sort through all that sequencing data to try to find any evidence of cell-free DNA that's coming from any possible tumor in the patient. Most of the test development and the analysis that's been done up until this point has been on the Leaf-Brown-Weeny syndrome group of patients that we have. We're currently kind of replicating those results in other groups as well, but I'll talk a little bit about the results from the Leaf-Brown-Weeny group. So in our Leaf-Brown-Weeny syndrome patients, we did find that our cell-free DNA blood test is able to find cancer either at the same time as standard clinical standard of care imaging, for example, MRIs, things like that, or we're able to find it earlier, which was good news. Overall, we found that what we call a negative predictive value, which just means that if the blood test comes back as negative, what are the chances the patient is actually negative? The patient doesn't have cancer. And that was about 98%. So in 98% of cases, when a blood test was negative, the patient didn't have any evidence of cancer. And then kind of on the opposite, on the flip side of that, something called the positive predictive value, which just means when the blood test comes back as positive, what are the chances the patient actually does have cancer? So what are the chances that that's a true positive? And this was around 50%. So in about 50% of cases when the blood test was positive, standard cancer screening that the patient had, like MRI, also was able to find that cancer. So you can kind of gather from that, hopefully, that cell-free DNA testing is not perfect. So there is that chance of a false positive. And it's something we're always working on and want to minimize the amount of false positives we get, because of course, it's a lot for a patient to get a positive and then have to do the follow-up investigations only to learn that it's a false positive and they have to go through all of that. So we want to minimize that, but it's something that is the case with cell-free DNA testing. It's also the case with most screening technologies and methods that we use in clinic. So that was kind of a very brief overview. I didn't really show any slides for the results just because it can get quite complicated. And even for me, I'm not a bioinformatician, so I didn't kind of go through that in detail, but I hope that was clear and kind of there was a bit of a takeaway, but I'm happy to answer anything about that. The last thing I briefly wanted to mention is just the future of CHARM and where are we going next. So our group recently got some funding from the Canadian Cancer Society to run CHARM prospectively. So meaning we would collect blood samples from patients and actually return the results real time to those patients and their doctors for follow-up. So on the slide here, I'm just showing an overall rough plan for the trial. We're still in very early stages, so a lot of logistics still need to be sorted out. But the plan is to recruit about 1,000 patients across Canada. And there's 5 syndromes we're focusing on, which I've listed here. So kind of similar to the work we've done in our initial CHARM, which is breast and ovarian, Lynch, NF1, Leaf-Brown-Weeny, as well as hereditary stomach cancer. And we're going to enroll 1,000 patients. We're going to divide these patients into 2 groups. There's a control group and an experimental group. So patients in both groups are going to continue getting the standard of care cancer screening that is recommended by the province. But patients in the experimental group are going to get kind of an additional layer of cell-free DNA screening. And we really want to compare the difference when someone gets cell-free DNA screening in addition to standard of care screening, like things with colonoscopies or mammograms, things like this, versus patients who are just getting standard of care screening. So patients for both groups are going to give their blood sample every 4 months. The blood collected from the control group is going to just be stored for future research. And then the blood collected from patients in the experimental group is going to be looked at. That cell-free DNA is going to be analyzed and sequenced. And the patient's doctor, once it's sequenced, the patient's doctor will be told whether we were able to detect any cancer in the blood or not. If we don't detect any cancer in the blood, because that negative predictive value that was around 98–99%, we're hoping that could provide patients with some reassurance that, okay, I'm cancer-free, because there's so much anxiety waiting for that next standard of care surveillance. So hopefully that can provide patients a bit of reassurance. If we do detect cancer in the blood, then the patient's doctor will follow up on that and will order any necessary confirmatory testing to actually see if the cancer is present or not. So that was a very brief overview of the plan. We are definitely very excited to get it up and running, and I just wanted to share a little bit about it with you, though certainly, like I mentioned, a lot of details still need to be worked out, but I'm happy to answer at the end any questions you have about the study currently, the future of CHARM, anything I'm happy to answer. And yes, thank you for having me, Ivana, Stephanie, and Mary, and everyone else. And I think I'll pass it back to Ivana. Yeah.
Thank you so much. Yes, we'll save the questions for the end, but we said, just want to hear about the possible future use of this testing for individuals with the RB1 mutation. So Stephanie, I'll pass that over to you.
Perfect. Thanks, Ivana. Can you hear me okay?
Yeah.
Okay. I will be brief. Mary and Julia, thanks so much. Those were wonderful presentations. So we are very excited to try to collaborate with the CHARM group. I'll talk briefly about a study that we're hoping to get up and running shortly. We're trying to work on the protocol, and we're in the phase of seeking funding. But we're hoping to collaborate with the CHARM group to assess their cell-free DNA blood test for our group of patients, so retinoblastoma survivors. So our research question is really, can this blood test help us to find second cancers in our population at an early stage, so prior to symptom onset? So Julia briefly just mentioned retrospective versus the prospective arm of CHARM that's starting. We would be trying to develop a more prospective type of test. Ivana, can you go back one slide there? Thank you. However, the difference between our study and the prospective study that CHARM is developing for some other cancer predisposition syndromes, as we know, retinoblastoma at present doesn't have a standard of care protocol for screening. So instead of doing a comparison, we would really be following all participants the same way with the cell-free DNA-based test. So our plan is to recruit retinoblastoma survivors from across Canada. As Julia mentioned, we would aim to do this blood test at enrollment, so once the participants join the study, and then repeat it every 4 months for 2 years. And as Julia mentioned, we would be looking at the cell-free DNA, looking for any signal that a cancer is present, and also looking for changes over time in the cell-free DNA. A positive test, so these individuals would be followed by an oncologist or other physician, and these would be followed up by other diagnostic tests like MRI and others. So Ivana, you can advance now. The second component of the study, which is very important, is going to be patient engagement. And really, this is all being done on a research basis right now, but when we think about moving forward, that this being implemented into clinical practice, what's really important to consider is the perspective of the participants and our community. So we want to understand patient priorities when it comes to screening or surveillance and acceptability of this kind of protocol. And ultimately, our broader goal is a dedicated program across Canada for lifelong surveillance for individuals with heritable retinoblastoma. So we're going to be creating a patient partner working group. This is individuals with lived experience that will join us as members of the research team, so not as participants in the study. And these individuals, we hope, will help us develop the protocol for this study and also recruit participants in collaboration with CRAB. We'll also develop questionnaires. So these would be given to participants at the beginning of the study and then towards the end to gauge how they felt the study was, what was acceptable to them, what were certain challenges and benefits that they saw from participating. And the working group would also collaborate with us in holding interviews with participants to get a better sense of their experience. So I know we've brought this up at the past two CRAB retinoblastoma research days, and several people have come forward interested in participating as part of the working group. We haven't forgotten about you, we're just not quite at that stage yet. But if anyone else is interested, please let myself or Ivana know, and we'll let you know about our next steps moving forward. So I'll end there. I think we have some questions to bring up to the group, and really we're hoping to hear about people's experiences or their thoughts on this type of surveillance. Julia brought up some great points, which are the potential for false positives, negative predictive value. These are all sorts of things that we want to hear from the group in terms of your thoughts.
Okay, so you can be, I'll sign up, I'm the first one. You guys all know that I'm very excited about the possibility of this. You know, I guess you've heard me talk about, you know, the fact that we don't have a protocol for screening for second cancers. And I really think that, you know, it's very, very important. So yeah, I'd be the first person in line for that. And I know there, you know, definitely are drawbacks as well. But I think, you know, all in all, it's, you know, I really think that this program, if it ever gets off the ground, will definitely be a plus for people. But anyway, that being said, so I'm just going to put it out there. What questions or concerns to those at risk for second cancers have about this potential screening method? Would anybody like to jump on and give us their opinion on that? My gosh, we have a lot of shy people here tonight. I know there are others at risk online. And I know, you know, you've heard now that, you know, yes, there are some drawbacks, but maybe you can tell us what you might think.
Terry Kelly here, if I may.
Okay, Terry, go ahead.
Oh, Terry.
Hi. I think this is fascinating. So you put me in that list. I'll follow you there, Mary. So you put me on the list for the study. So if I understood correctly, Mary, when you talked about there are DNA markers in the blood that can, if you know, by using this technology, can detect cancer 4 years before it's detected by other means. Did I get that right?
Yeah, that was in one of the studies. Did say that they were able to find it, you know, about 4 years before it was clinically detected.
Okay.
Whether or not the CHARM program has been, well, obviously it hasn't been in vogue for that long. So, but we know that in other studies that have been done, you know, it has, you know, early detection has been there for sure.
Sure. Okay. So I just want to make sure that I was hearing that correctly. So I think this is fascinating. And as you know, Mary, I'm really interested in, it's great to be able to detect and through, you know, for people who are possibly predisposed based on, you know, other cancers such as retinoblastoma. What about how much study is being done in prevention, such as making sure the mitochondria in our body are fortified, that would possibly change what is being will change the DNA, I suppose. And we know that there are studies that show that vitamin D3 also in people who are are low on vitamin D3, there are a lot of genes that are turned off or not activated based on the absence. So when you have someone who's fortified well with vitamin D and then other nutrients that fortify the mitochondria, that from my pedestrian studies have indicated that that's possibly a way of preventing cancer, despite the fact that you may be predisposed based on an earlier event such as retinoblastoma. Who can answer that one? Dr. Galley, Mary, one of you people.
No, I can't answer that, except that that's very difficult research. And I think there's probably lots of things going on in that area, which I'm not involved in at all. But I think apart from the things we all know from our general diet and healthy living and sleeping long and all those sort of things that we should all be doing, I don't think there's any big lead there that I know of. Stephanie may have heard of something, but I don't know. Or maybe Katrina knows something that's coming in the wind, but I don't.
So treatment is exciting always, but I'm really interested in prevention. And you
could look at CHARM with recognition of a cancer beginning 4 years earlier or any time earlier when there's no symptoms, and destroying it is a form of prevention.
Right.
Certainly optimizing minimizing the treatment that would be needed.
Right. So Mary, you and I have talked about this before as well. Have you read anything since our last discussion around all of this?
Yeah, I mean, I think, for many people, when you have any kind of secondary cancer risk, because even when I was working as a genetic counselor, I mean, I dealt with a lot of people with a lot of the other cancer syndromes that they talked about in the paper, and a lot of the ones that are now being studied in CRAB. And there's certainly, for all of us, I mean, there's things that, we should probably be looking at doing better and whatever, and that might help. Certainly if we had healthy diet, if we lived, in a better way, it might help towards it. But I think, in terms of somebody who has a specific risk of a second cancer, like many of us now who are survivors of RB or have the mutation and therefore are at risk, I think what we need to really do, apart from trying to live as healthy as possible, is to really do what we can to try and detect the second cancers early. And, as you know, from your own family experience, I hope it's not bad if I say this, but Terry had a brother who, had second cancers starting at 19 and 20, and then, in his mid 20s ended up with a brain tumor, and then he had melanoma at 19 and 20, and then mid 20s an astrocytoma of the brain, and then ended up having a recurrence of the melanoma, and he died in his 20s. And so for many of us, we don't want something like that to happen. So if there were some type of screening that was possible, that didn't expose you to a ton of x-rays and whatever, that would be great. On the other hand, and I'll just throw this out because it's kind of like going down the rabbit hole sometimes. Like, I was just gone. I can't even remember why I had the ultrasound. I think I had problems that were related to gallbladder. And so they were, doing an ultrasound, and in the ultrasound looking for something totally not, to do with my gallbladder. They said, oh, you have this kidney cyst. And so, okay, then, I went back in to have a CT for the kidney cyst. And then they said, oh, well, we're seeing this, thing on your pancreas, and that might be, another cyst there. And so we need to do this. So it's like, one thing that had nothing to do with the other led me down this whole pathway of getting a lot of radiation. And in the end, they basically said, oh, well, no, there's nothing there to be concerned about. And, an MRI and 3 CAT scans later, I still have no answer, right? So at least with the blood screening, it might not be perfect. And it may lead to, if something comes up on that says, okay, we've seen some tumor DNA, then it may be a little bit more acceptable, maybe, to say, okay, well, now we can, start going down this line of looking at clinical screening, because at least there's a better reason to do it now. I don't know. I mean, I'll throw that out to people, and how would you feel about doing that? And would you, feel comfortable in even, sharing experiences that you might have had yourself? I know some of the people online may be older retinoblastoma survivors and may have gone down that route of having other cancers. So if anybody...
I won't monopolize the conversation. If I may just finish with this. There are lots of studies that have been done around epigenetics, for instance, with identical twins, and within any family. So if someone ends up in an environment, less stress, different, epigenetics is a result of environmental influencers. So that's a given. We know that. And so sometimes people call me frank candor, but I'd like to say that, is it possible that CRAB could maybe embark upon a study and start? So it's great for what we're talking about right now this evening, but then maybe if we could consider having a look at other ways of prevention, because there is science, or I should say there are studies to show that that your environment and other forms of epigenetics can absolutely determine a health situation despite your genetic predisposition to something. So, question: is that something that could happen within CRAB, that we could embark upon something like that?
We could explore that topic maybe in a future cup of tea, if we can find like the right article and the right partnerships. I think that could be a great conversation for a new cup of tea topic.
I'll bring the tea.
Perfect.
But could I just add, if CRAB CHARM ends up with enough CRAB members who are tested, and you have true positives and true negatives, you also still have the DNA. So then at some time, if you have enough, you could start to mine that DNA for features that, particularly if you had identical twins, compared to their brother who doesn't have that same thing or whatever, you could work through with very fancy techniques using that same blood sample to find out what might be addressing Terry's desire
Brilliant.
to have something to find out more about how to.
Yeah, that's very exciting. I think that's extremely important, and sometimes I think we, I mean, all through. I won't get on my little soapbox here, but that's one of the things in our culture where looking to address the symptoms, but there's so much money could be saved, I believe, with a prevention.
Well said.
Many.
So just a couple of more questions, maybe to the clinicians online tonight. How would you feel about this screening method for your at-risk patients? Anybody want to say what they would feel about that?
Of course, I'm totally biased. I think every patient, every H1 person should have this screening for the rest of their life.
I got a note asking about, along those lines, is how do we make sure survivors affected by the germline retinoblastoma get plugged in to a study, the study, that are not in the community right now? How do we reach those folks who are out of the eye clinic at Sick Kids and haven't quite heard about the RB research community? I haven't signed up yet.
Could I jump in that we actually know a lot about the patients with retinoblastoma who ever even touched Sick Kids? And through Catherine Payton, she knows a lot of patients for the whole of BC going way, way back. So those are the people, particularly we do know those that had that terrible external beam radiation. And those will be prime ones, as far as I'm concerned, that we would push to the front of the line for having this testing in the study. And they're very useful for the science too, because they're more likely to have a positive, which really teaches us something. Yeah. And they will also benefit more because they're at higher risk, and finding things earlier is very useful to them. We predict, we don't know because we haven't done it yet, but to me, it's a no-brainer. This is a game changer.
Of course, the organizations of the blind or for the blind, CNIB, CCB, they'll have their members, and members who would, many of them open to respond, I'm sure.
And then Stephanie has to figure out the right way, or Katrina, to approach people remotely when we're not caring for those persons, to invite them into research. And there's a whole ethics thing around that too.
Can I just add one perspective? I'm a big advocate of making sure we keep consolidated data, but with really good tests. And there's some of these things that are becoming available that people hear about. And if we're not doing it in a consolidated way with expertise and good backup behind us, what happens is people seek out what else might be out there for purchase. And many of the for purchase tests are not the same as really well done, proper tests. I'm not sure that I even have the right language to explain that. And I run into that all the time, even within the health system, with somebody telling me, well, it's an RB test, it's good enough. It isn't. And I think if we get out ahead of this with good tests, well done, and a protocol, and starting with a high risk target group, you will create something that the Canadian patients will benefit from, and that will be really hard for the health system to walk back from. If we don't do that, they'll have an opportunity either to say that it's too diffuse, they won't do it at all, or this other place in some other country is offering a cheaper test that, quotes, accomplishes the same thing, where you can't actually follow along what's going on. I think that that's a risk. I don't mean to put a negative on it. I think this is a positive and this would be the way to go. But the risk of doing nothing and leaving it open is that people will find something that kind of works for them, because people are anxious to get answers and to participate in something new and to enter the kind of brave new personalized medicine world, and to do what you can to identify early. So I think it's a wonderful idea. I think we need people collaborating to figure out how to roll it out. And I think, yeah, it's not easy to talk online, but people are looking on their own anyway. It's a matter of being out there in front of it, as Brenda and company have often been.
That's a really good point. I think that would be a really great discussion to even carry forward, but I know we're at 9 o'clock and I know Helen had her hand raised. Maybe that could be our last comment before the clinicians head off to their meeting, and anybody who wants to stay can continue with the discussion.
Oh, thanks for giving me the opportunity. I'll be quick, and maybe it's just something for the survivors and parents on the call to think about. But given that we're embarking on this research study where we don't know how well this will work for RB, and participating in a study might mean you get a false positive. So you get told, we found a marker of cancer, but actually it's not. How would you feel about that? Getting a sort of an error result. You're contributing to research, but there might be some hiccups as we're sorting things out. And thinking about how we communicate those results to families as well, so that they're understood for what they truly represent. I was curious to know how survivors and parents thought about that part of it, because we're talking about it as if it's going to work, and it will eventually, but there will be some gray area before we get there.
I just personally, I think that having any kind of move towards potentially finding cancers earlier, regardless of, you know, what the risk of a false positive is still better than what we have now, which is no real screening protocol. And so I think you're better with something that, yes, it has its drawbacks, but it also has its pluses. And I think for most people, that might be, the way that they would want to go. It's better to have something than nothing, right? And to contribute towards that research, it might take us 10 or 15 years to get to something that will work well. But you'll have that, idea that you've helped others as well in doing that.
I agree, Mary. I'd echo those same comments. Obviously, my daughter doesn't have hereditary, but if she did, I would rather know sooner and have a false positive that I needed to follow up on, and have it turn out to be negative than to have had no tests or no screening at all and have waited too late until it's too late to do anything about like that. It's too far down the road then. So I agree. I'd much rather deal with getting a false positive than not knowing at all.
Good to hear that.
Leah had said it was a 50% chance that, if I'm saying it correctly, 50% chance that there could be a false positive or a positive that then is not shown, it cannot be found at the time. So I'm not sure if you're still here, Julia. I'm just wondering, does that also mean that there could be a chance that just something was too small that could be seen on imaging?
Yeah, no, that's a great point. And for the Bifrau-Meany syndrome cohort that we kind of base those positive predictive values on, the follow-up imaging is limited. So we're still looking at the imaging now to see, at the time we came up with those numbers, maybe we were following them only 1 or 2 years after the test was done. But, does something come up 3 years, 4 years later that maybe it's not actually a false positive, but maybe it just clinically isn't able to be found? So can't say that for certain, of course, but no, it's a fantastic point, and it's definitely something we're keeping in mind. So it's very possible that the false positive rate is lower, but yeah, don't know that for certain at this point, but important to keep in mind.
We are past 9, so anybody who has that second meeting to go to, don't blame us for keeping you longer. But if anybody who does want to continue chatting, I'll keep this link open for another 15 minutes or so. And I also wanted to share a note from Mary if you wanted to share this with everyone.
I just think it's really important to contribute to research by participation in Canadian trials to study, the use of this technology. And, I think as survivors, we need to advocate for the use of new screening technologies for this. And we really need to stay informed about whatever new technologies are available. And, that's through involvement with CRAB and the Canadian Retinoblastoma Society. If you're not involved, you're not going to find out. And the more we can encourage people to join and listen and find out what this new information is all about, the better off we're going to be as a full community. So yeah, I encourage everybody to get involved.
Thank you so much, Mary. And while I have you all here, thank you for presenting, and for all our guests that we have, Stephanie and Julia. This was very informative, and we're really excited to keep hearing updates and learning more about what you guys learn.
Yeah, thanks everybody. The presentations were great. Lovely.
Does anybody want to stay and chat and maybe share their experience with screening or any feedback about screening? We have a question here. So if a screening protocol were to do a blood test 3 times a year, would that be too much of a burden? And what would impact your decision of if that is too much?
Well, I can just, again, I will say, even though this is going to apply to me, but if it meant that you could find out sooner, up to 4 years later, why wouldn't you? Like 3 times a year for a blood test, I really don't think is that burdensome. Most people, I think, are probably going to the doctor 3 times a year anyways for other things, but really, I think what could come out of that, not at all, from my perspective.
Julia, has there been any feedback from patients who are in the study? I think you said that there hasn't been like the results sent yet, but the ones who have done the blood tests, have anyone said it was too much or too little, or any sort of feedback the patients have had?
Yeah, so for the current study, it's every 6 months to a year. So we haven't had anyone saying it's too burdensome or too much. I think part of the reason they're able to do it in most cases close to home, so it's not like a huge commitment. Definitely kind of doing it it will be 3 times a year. It's more. We do have like a patient advocate, patient partners group that helps us with the study development for the trial, and for them 3 times. I mean, it's 5 individuals, so of course can't speak for everybody but we had discussions with them, and their feedback was that it's very reasonable, especially if they'll be able to give blood locally, because we do have patients living quite far away from outside of Toronto. So if they're able to give blood locally, then it's not a huge burden. So yeah, I think 3 times a year, kind of the consensus was from everyone I've heard, that it's a good number. A couple patients would say even more, kind of as much as possible, but of course they kind of have to balance cost and also more blood tests, more rabbit hole. Like it's a fine balance, but yeah.
Can I ask a question? Can someone explain the ethics part of it to me? I guess just so that I understand, or does anyone know like what the ethics issue is, and I guess how you approach past patients?
Do you mean like from a recruitment perspective?
Yeah. Yes.
Yeah, so I can speak kind of on behalf of UHN and Mount Sinai. We can't just really go ahead and call patients up. So usually patients have to be introduced to a study by someone in their circle of care. So like a physician, a nurse, a genetic counselor. There are some changes now, I will say, at UHN, which are great, where patients actually have the option in their electronic medical record, maybe at Sick Kids as well too, I'm not sure, where patients have the option in their electronic medical record to express interest in research participation. And so they can kind of change that as much as they would like. And if they say they are interested, that in general research study teams can contact the patient without having to be introduced by someone in their circle of care. But it's kind of a, I think, safety mechanism. So, you know, physicians, gender counselors who know the patient maybe know if they're going through a lot right now, maybe it's not the best time to approach them for a study. It kind of adds a level of, I think, protection for the patient. And also they're not burdened by too many research projects. And maybe they feel, you know, it's a lot. They keep saying yes to all these research projects and it all just becomes too much for them. So I think it's nice to have that. I think it's important to have that, not a barrier, but kind of a check. But so it is with patients, for example, at Sick Kids who have been discharged and aren't being followed anymore. It is trickier because they're obviously not seeing someone who's within the circle of care, but we kind of can, what can sometimes be done is like a mail out. So we send, if their address is still on file, if it's the same one, you can send a letter. And if they're interested, they can contact the study team. So it's less pressure as well because they received the letter. There's no one face-to-face where maybe they feel more pressured to participate, but it really is kind of making sure that patients don't feel pressured to participate. It's fair. It's not too much of a burden. Things like that, but quite a bit to consider, definitely from a perspective. Yeah.
Thank you.
I think a big part of the problem with RB survivors as well is that, you know, because there's no real clinical protocol, you know, after you probably leave Sick Kids in treatment, you're kind of out there and lost in Never Never Land, not knowing what you really should be doing and not really having any contact, you know, with an RB group kind of thing, right? So there's probably lots of people who could avail of it, but the problem is how do we get them in, and how do you get them to know about what's available? And, you know, we struggle with that through a lot of things with CRAB, you know, and we use social media and all that kind of stuff for it. But that's one of the biggest problems, is letting people become aware. And how can you do that and still meet the requirements of, you know, confidentiality and all the things that go with that, right?
Yeah, it's just so, I struggle with this so much because of, I don't know, maybe my perspective is different, but as a parent, like, I would want, for me, I want to do anything possible to help someone down the road, right? Like, if it means that, you know, then so the next person's journey is easier because there's better treatments or better options or earlier diagnosis. I like, obviously we're not going to benefit from that, but I think I benefited from other things that, you know, have happened down the road, and I would hope that I can pass it on to someone. So I guess it is hard for me because I would of course raise my hand for anything that came along, but I know that's not the feeling of everyone. And I guess some people just want to move on, or they're just out of the loop, like you say, right? So it's hard to get them back in that loop.
Mm.
It's hard. I also think though too, it generally is a fairly small community, I think, just given the population size of the number of patients with RB, and given that I think a lot of them have been treated by Dr. Galley, right? So it's always like, but like you said, then it's hard to contact them or go around the ethics of that too, right? But I'm sure she has a list, right? But yeah.
Oh God, yeah. If we could just take her list and go with it,
just
great,
call
right?
these people up and ask them, right? But anyways.
Yeah.
No, I think it's wonderful if it can be done, and if get the funding to make that happen.
We'll definitely keep sharing updates. I know it's a long process.
Mm-hmm.
So we'll definitely let you know and keep you updated.
Yeah, but
So
it sounds like
guys so much.
It sounds like traction is being made, and if the RB group can almost piggyback off of like the work that Charm is doing, right? I think that's great.
I think it's really helpful to have the comprehensive newsletters with all the kinds of information that's available, because I know some long-term survivors too who used to go to Toronto. And so to avoid ethical things, like I could just say, well, there's this newsletter, here's all that's available, and people are trying to keep in touch and up to date. So that's really helpful too.
Yeah. And that is sometimes the way to share it, is to say, listen, I heard about this. You know, you could go on and you could listen to this cup of tea and find out a bit more information. You know, it's word of mouth, really, that helps get that stuff happening sometimes. And that will, you know, kind of you get around the ethics of it, and still it's still ethical, because you're just passing information that people need on to someone, and they can choose to participate or not, right? So tell all your friends and family and anybody who's at risk. Yeah.
Work on it.
Well, this was a great discussion. Thank you guys for staying and for continuing our chat. And I'm gonna have to take my son to bed, but
yeah,
everyone have a really great night, and I will let you know when the YouTube and the Spotify and the podcast is up, so you could share that as well for anyone who's missed it tonight.
Super. That was
wonderful.
Really
Thanks everybody.
Thanks
Good
Mary.
night.
Thanks, Yvonne. Bye-bye.
Bye.